So question number 1. In a model cell, the ratio of calcium between ECF and ICF is 10,000:1. Calculate the equilibrium potential of calcium. So all of you know that this will be calculated based on the Nernst equation, which is saying that equilibrium potential is equal to RTZF log of concentration of the ion outside the cell upon concentration of the ion inside the cell. Now this is natural logarithm. If I convert this into log base 10 and if I put the normal value of this constant, that is R, T and F, what will happen? This equation will be modified to plus 61 millivolt upon Z log base 10 concentration of the ion outside upon concentration of the ion inside. So now in this question, the ECF calcium between outside and inside is 10,000:1. That means I can say this is 10 to the power 4, right? So this is 10 to the power 4. So if I put it into this formula, plus 61, Z is the valency. So valency of calcium is plus 2. So now this is log base 10, 10 to the power 4. So we all know that log 10 to the power 4 is nothing but 4. So plus 61 multiplied by 4 upon 2. This is nothing but plus 122 millivolt. So the first question answer, that what is the equilibrium potential of calcium in this cell, is plus 122 millivolt. You know that normal ratio between ECF and ICF calcium is 12,000:1. 12,000:1. This is the normal ratio. But in this question, although it is given 10,000:1, actual ratio is 12,000:1, and that's why the equilibrium potential of calcium in a mammalian cell is plus 132 millivolt. This is the normal or normal equilibrium potential in a mammalian cell, right? Now question number 2. One person was performing a complex sequence of finger movement. Which of the following brain areas are active during this complex movement? So always remember, for simple kind of movement, so if I move my thumb like this, if I move my finger like this is a kind of simple movement. This is performed only by the primary motor cortex. But whenever your movement become complex, sequential or bilateral movement, okay, suppose I am doing this kind of complex movement, this kind of complex movement always require the help of supplementary motor cortex. So please make it clear. If you think that you have to do a complex movement, suppose I have given you instruction that you have to do a movement like this, you are only thinking but you are not doing the movement, your supplementary motor cortex will be active. But whenever you are actually performing the movement, obviously your motor cortex has to work, otherwise the movement, the muscle movement will not be there. But along with that, you require supplementary motor cortex. So supplementary motor cortex is for complex sequential movement and second is for bilateral coordinated movement. So in this question, my answer will be primary motor area as well as supplementary motor area. Now what about this premotor area? Premotor area is responsible for setting the posture before the onset of movement. Okay, it sets the movement. Suppose you want to move your arm like this, you have to set your shoulder in a fixed position. The setting of posture before the actual onset of movement is done by premotor cortex. Okay, so this is all about this question. Now question number 3. So at which point of the action potential potassium permeability is maximum? Now this is a simple question. If you look at the permeability curve of sodium, then it will look like this. So sodium permeability is peaking with the peak of action potential and rapidly it is decreasing because sodium channel is a very fast channel. So this red color curve, this is the sodium permeability curve. Why it is looking like this? Because the channel is a fast channel. On the other hand, if you look at the potassium permeability, potassium channel is a slow channel. So it will start opening from same point, but it will take long time for complete open up, and maximum permeability will reach at point number B and then the permeability will decrease gradually like this. So now if you look at this action potential, you are finding out that maximum potassium permeability at which point, that is the point number B. And maximum sodium permeability will be which point, that is the point number A, that is the maximum sodium. But be careful, if the question is like this, that potassium permeability upon your sodium permeability, this ratio is maximum at which point, then look at this after hyperpolarization part of the action potential. This part, there is only and only potassium permeability is present. Sodium channel is already inactivated. So during this after hyperpolarization, potassium permeability is present, but sodium permeability is almost 0. So what will happen to the ratio? Ratio will be infinity, maximum. So that's why if the question is this potassium upon sodium permeability is maximum at which point, your answer will be point number D. This is all about the question. Now question number 4. Malignant hyperthermia is caused by mutation of. So all of you know that malignant hyperthermia is nothing but mutation of the ryanodine receptor channel. All of you know that this ryanodine receptor channel is present at the level of sarcoplasmic reticulum, and due to mutation, the channel become hypersensitive. There will be huge amount of opening of this channel, and huge calcium will influx into the cytoplasm, which leads to heat production, and that will produce malignant hyperthermia. Now problem is that this ryanodine receptor 1, this is present at the level of skeletal muscle. Ryanodine receptor 2, this is present at the level of myocardium, and ryanodine receptor 3, this is present at the level of smooth muscle. So all of us know that malignant hyperthermia is the problem of skeletal muscle. That means the mutation is at the level of ROIR1, right? It does not involve the ROIR2 and ROIR3. This is all about the question. Question number 5. Maximum sodium is reabsorbed from lumen in proximal renal tubular cell. So question is from the luminal side, and it is the proximal tubules, right? So please remember like this, that at the level of proximal tubules from the lumen, there are 3 major group of transporter. One is transporting sodium along with glucose. So this is nothing but SGLT. Second group of transporter is sodium is reabsorbed along with phosphate, citrate, amino acid, etc. So this is also various co-transporter system, right? And the third group is sodium is reabsorbed along with H plus secretion. This is nothing but NHE. Note down that from the luminal surface, NHE reabsorb 50% or the maximum sodium. Another 45% is reabsorbed by this co-transporter molecule, and only 5% is reabsorbed by this SGLT. So in this MCQ, maximum sodium is reabsorbed by sodium hydrogen exchanger molecule. Answer B. But note down, if the question is from the basolateral surface, which transporter reabsorb maximum sodium, your answer will be sodium potassium ATPase molecule. It is said that almost all the sodium reabsorption is linked to sodium potassium ATPase pump. That means on the basolateral aspect, 100% of sodium reabsorption is linked to sodium potassium ATPase pump. So if the question is basolateral aspect, sodium potassium ATPase pump. If it is from luminal surface, then NHE. If the question is not specifying anything, again your answer will be sodium potassium ATPase pump, because all of these transporter are secondary active transporter. They are linked to sodium potassium ATPase pump. Question number 6. Dissociation curve of adult hemoglobin, fetal hemoglobin, myoglobin and carboxyhemoglobin are shown here. You have to identify which curve indicate myoglobin dissociation curve. So Note down from here. Curve number A. This curve is nothing but the normal curve. Okay. You may ask that how do you understand? Look at the P50 value of this curve. P50 value. That is a 50% hemoglobin saturation. If you look at here, so this point indicate this is the 50% saturation. How much partial pressure of oxygen? If you drop a perpendicular from here, you can note down that this is almost 26 millimeter of mercury. So P50 here is 26 millimeter of mercury. This is nothing but the normal curve. So now in curve number B, you are finding out that the curve is on the left hand side of the normal curve. Okay, and here if you find out that question number 6. Dissociation curve of adult hemoglobin, fetal hemoglobin, myoglobin and carboxyhemoglobin are shown here. Which curve indicate myoglobin dissociation curve, right? So first of all, the curve A, it is nothing but the normal curve. How do you understand this is normal curve? So I am writing here, this is normal curve. Look at the P50 value from this curve, P50. So if you look at here, this is the 50% saturation. So if I drop a perpendicular from this 50% saturation, I can find out that the partial pressure of oxygen is almost near equal to 30 millimeter of mercury, and we know that P50 of normal adult hemoglobin is around 26 millimeter of mercury. So from this I can identify that the curve A is the normal curve. Now the curve B is located on the left hand side of this curve, and here if you calculate the P50 from this point, if you calculate the P50, you will find out that the P50 value will be lesser than, so if you drop a perpendicular like this, you will find out that the P50 value of curve B is lesser than 20 millimeter of mercury. This is nothing but fetal hemoglobin, where P50 is around 19 millimeter of mercury. So the curve number B is nothing but fetal hemoglobin, right? Now C curve is also located on the left hand side of the normal curve, but the shape of the C curve is like a rectangular hyperbola. That means this is the typical curve of myoglobin. So this is the typical curve of myoglobin. Okay, so curve number C indicate myoglobin dissociation curve. If you argue that how to identify, look at the normal saturation. Okay, at 40 millimeter of mercury, the saturation of myoglobin is more than 80%. But what is the normal saturation with 40 millimeter of mercury partial pressure of oxygen in adult hemoglobin? That is nothing but 75%. You know that 40 millimeter of mercury partial pressure is the venous blood partial pressure of oxygen. So at that, adult hemoglobin is only 75% saturated. But look at this curve number C, that is the myoglobin. It is around 95% saturated. So 95% saturation with a partial pressure of 40. That is the identification point of this curve, and the shape of the curve is also rectangular hyperbola. So what is curve number D? Curve number D is nothing but carboxyhemoglobin, that is the carbon monoxide poisoning, because all of you know that carbon monoxide has huge affinity for hemoglobin. So even little amount of carbon monoxide will give huge amount of carboxyhemoglobin formation. That's why the curve is located on the left hand side of all of this curve. So this is all about question number 6. Question number 7. Question number 7. Adducted and flexed posture of arms in decorticate rigidity is due to which of the following? All of you know that in case of decerebrate rigidity, right, if there is damage to the upper pontine region, then all of the forelimb will remain in a extended posture, and this extended posture of the forelimb is due to pontine reticulospinal tract. Reticulospinal tract, which causes contraction of all the extensor muscles group in our body. On the other hand, in case of upper midbrain damage, that is the decortication, you can find out that upper limb is in a flex posture and lower limb in a extended posture. This flex posture of the upper limb is due to rubrospinal tract, okay, activation, and this extended lower limb is due to again this pontine reticulospinal tract activation, right? So upper limb flexion is due to rubrospinal activation. So why only the upper limb flexion? Because rubrospinal tract supply up to the level of cervical region of the spinal cord. That's why it's only causes flexion of the upper limb. But pontine reticulospinal tract causes extension of the lower limb in decortication. So answer of this MCQ is nothing but rubrospinal tract mediated, right? Question number 8. Which of the following receptor detects mechanical pain, particularly pressure from sharp object? Remember that TRPV, that is the transient receptor potential channel V2. This is the receptor for detection of temperature when it is greater than 52 degrees centigrade. So I am writing temperature greater than 52 degrees centigrade. Then this is the receptor for thermal pain. ASIC, this is acid sensing ion channels. This is responsible for detection of H plus ion mediated pain. So this is basically chemical pain. This MGRPD, this is MRGPRD, that is mass related. This is known as mass related G protein coupled receptor type D. Mass related G protein coupled receptor type D. This is the receptor for mechanical pain. Mechanical pain, particularly pain created by sharp object. So this is my answer C. And what about this TRPM8? This is transient receptor potential M8. This is responsible for cold pain when the temperature is below 17 degree centigrade, right? Below 17, or the range is 8 to 27. This is the TRPM8. Question number 9. Activation of which of the following reflex responsible for tachycardia? Basal-Gerry's reflex, Bain-Beige reflex, Cushing reflex, J reflex, and reverse Bain-Beige reflex. So first, Basal-Gerry's reflex, it causes bradycardia as well as hypotension. Bain-Beige reflex, this is causing tachycardia if the reflex is activated by infusion of normal saline or blood into the body. Cushing reflex, again this is bradycardia. J reflex, this is the receptor present at the level of pulmonary capillary close to the alveolar wall, which is responsible for bradycardia and hypotension. So again it is bradycardia and hypotension. And reverse Bain-Beige reflex, obviously you can understand from here that Bain-Beige is causing tachycardia. Reverse Bain-Beige means if there is decreased blood volume or decreased volume of fluid in the body, the Bain-Beige reflex will be inhibited. That is reverse Bain-Beige reflex. So again it is going to cause bradycardia. So answer, tachycardia is caused by only and only Bain-Beige reflex among all of them. So answer B. Question number 10. Maximum expiratory flow volume curve is recorded from a person, that is given below. What is the total lung capacity? So all of you know this is a simple question. Total lung capacity is nothing but, this is the point which is nothing but TLC, and this is the point which is nothing but residual volume. So total lung capacity is nothing but 5.5 liter, and the difference between these two is nothing but force vital capacity. So in this question, force vital capacity is 4.5 liter and total lung capacity is 5.5 liter and residual volume is 1 liter. Hello student, we are going to discuss Insta number 11. So the question is, which figure best describe the relationship between alveolar ventilation and arterial carbon dioxide tension when the carbon dioxide is changed from a range of 35 to 75 millimeter of mercury. Now, all of you know that carbon dioxide is a stimulus for both peripheral chemoreceptor, that is the carotid body and aortic body, as well as it's also a stimulus for the central chemoreceptor, which is located at the level of ventral surface of medulla. Because of the stimulation of both of these chemoreceptor, carbon dioxide, obviously it is going to increase the ventilation of the person. Now, how this relationship, increase in carbon dioxide and increase in ventilation, how the relationship is that? The relationship is completely a linear relationship. So if I plot a curve like this, that x-axis is the partial pressure of carbon dioxide in arterial blood and y-axis is ventilation, then I will find out the relationship is nothing but a straight line. It indicates that whenever the partial pressure of carbon dioxide rises in the arterial blood, proportionally ventilation also rises. This rise is up to a partial pressure of carbon dioxide, that is 80 millimeter of mercury Ag. That means the linear relationship is followed up to 80 millimeter of mercury partial pressure of carbon dioxide. If the carbon dioxide is beyond that, then it can causes depression of the respiratory center also. And if you follow the line in opposite direction, that whenever carbon dioxide is decreasing like this, a point will reach where the ventilation is 0. 0 means the ventilation will stop for some time being. This point, carbon dioxide partial pressure is 37 millimeter of mercury. That means I can understand that if the arterial blood partial pressure of carbon dioxide is below 37 millimeter of mercury, it can stop the ventilation for some time, and that is nothing but apnea. That's why this 37 millimeter of mercury partial pressure is known as apnea point, right? So now with this discussion, you can easily understand that in this question, the answer is nothing but option number D and D, because we can find out the relationship is completely a linear. In option C, there is a plateau which is not seen within this range of 35 to 75 millimeter of mercury. So answer is nothing but D and D. Hello student, we are going to discuss Insta number 12. So if you look at the question, they are asking which condition at the AV node will causes a decrease in heart rate. So decrease in heart rate means we know that parasympathetic stimulation causes decrease in heart rate by increasing the acetylcholine at the level of nodal tissue. But here in option number B, it is given decrease in acetylcholine level. So we can easily rule out this option first. Then other three options in this question, they are related to action potential of the AV node. Now if you look at the action potential of the nodal tissue, then all of you have seen that it looks like this. It looks like this, right? Okay, so it looks like this. So there is a phase where the membrane voltage rises from -65 to -40 millivolt. This phase is known as the prepotential of the nodal tissue, that is SA node as well as AV node. Now same here, so this is prepotential. Now if I look at what is happening at the level of this prepotential, then I have to remember three things here which are responsible for prepotential generation. Okay, number one, there will be decrease in potassium permeability from this cell. So there will be decrease in potassium permeability. So if there is decrease in potassium permeability, That means I can understand that cell is losing less amount of potassium. Then there will be increased entry of sodium through a channel which is known as HCN channel. So sodium entry means there will be more and more positivity. Membrane voltage will rise up more and more. Along with that, it will also open up a T-type calcium channel in the later part of this prepotential, and because of which it will further move up to minus 40 millivolt, and then it will causes action potential generation, because minus 40 is a threshold voltage of the nodal tissue. So from this discussion I can find out that increasing sodium permeability, increasing calcium permeability and decrease in potassium permeability is responsible for this prepotential generation. So if these three things increase in nature, that means more sodium entry, more calcium entry, what will happen? This prepotential will changes its slope like this. If the sodium entry increases, if the calcium entry increases, what will happen? Obviously, this prepotential will rise to the threshold voltage in a rapid manner, and the second action potential will be generated like this. So that means this is nothing but increase in heart rate. So I can easily understand that decreasing the sodium, decreasing the calcium or increasing the potassium will causes decrease in heart rate. So if there is increase in potassium permeability from the cell, what is going to happen? Cell is losing more positive charge. That means there will be more and more hyperpolarization. Hyperpolarization means it will take long time to reach at the threshold voltage, and action potential will appear here. This is nothing but decrease in heart rate. So if I look back at the option, increases sodium permeability will increase the heart rate. Increase in calcium permeability will increase the heart rate. Increase potassium permeability will decrease the heart rate. So obviously our answer is nothing but C, C and C. Got it? Hello student, we are going to discuss Insta number 13. So the question is, bradykinin mediates pain by stimulating which of the following receptor or receptors? So all of you know that bradykinin is one of the most potent pain producing substances in our body. If you apply bradykinin, or if there is release of bradykinin at the level of angio tissue, what is going to happen? It is going to stimulate your sensory neuron. So suppose this is a cell body and this is the part which is present at the level of your skin, and this is the part which is present at the level of spinal cord. So if there is presence of bradykinin here, what will happen? It will stimulate this sensory neuron, and because of the stimulation, the sensory neuron is going to produce substance P and other transmitter from this region. So this will causes enhance in pain transmission. So how this bradykinin is stimulating this sensory neuron? It can stimulate both B1 and B2 receptor. So answer is both B1 and B2 receptor, that is D. But you must have to remember that generally bradykinin produces acute pain by stimulating this B2 receptor. So please remember, B2 is responsible for acute pain mediated by bradykinin, and when there is chronic pain, when the tissue is inflamed, the inflammation causes increased expression of B1 receptor in the neuronal ending, because of which B1 receptor stimulation produces chronic pain. So B2 is for acute, B1 is for chronic pain produced by bradykinin. Got it? Hello students, we are going to discuss Insta number 14. So the question is, which diagram best describe the relationship between ventilation and the oxygen tension when the oxygen is changed acutely from 0 to 160 millimeter of mercury, keeping the partial pressure of carbon dioxide and H plus ion constant. So if I decrease the oxygen, that means there is production of hypoxia, and we know hypoxia is a stimulus for peripheral chemoreceptor. But if you plot the curve between this decrease in oxygen and ventilation, then it will look like this. So suppose this is the partial pressure of oxygen in the arterial blood and this is the ventilation. So what is going to happen? Suppose this is 160 millimeter of mercury partial pressure, this is 100 millimeter of mercury partial pressure of oxygen, this is 60 millimeter of mercury partial pressure of oxygen. If the partial pressure of oxygen is changing from 160 to 100 or partial pressure of oxygen is above 100, it is not going to stimulate your ventilation or it is not going to depress your ventilation. So almost I'll get a flat kind of line like this, right? Then if I decrease the oxygen tension further, if I decrease the partial pressure of oxygen further, what I'm going to see? I'm going to see that the ventilation is rising but in a slow manner. But whenever your partial pressure of oxygen is below 60 millimeter of mercury, it suddenly rises the ventilation in a steeper pattern. That means I can find out the relationship between hypoxia and rise in ventilation is not linear like this. It is not like this. It is following a curve pattern. Why this curve pattern? Or why the ventilation rises maximally when the hypoxia or when the partial pressure is beyond or below 60 millimeter of mercury? Could you think of anything? So, whenever the partial pressure is decreased from 60 millimeter up to 100 millimeter of mercury to 60 millimeter of mercury partial pressure, what is happening? It is producing hypoxia, right? So, hypoxia is stimulating your ventilation by stimulating your peripheral chemoreceptor. But simultaneously, because of hypoxia, what is happening? There is more and more deoxyhemoglobin formation is also occurring. Because partial pressure of oxygen is less, means deoxyhemoglobin is more. More the deoxyhemoglobin means, deoxyhemoglobin is a kind of alkali in comparison to oxyhemoglobin. So, oxyhemoglobin is a strong acid, deoxyhemoglobin is a less strong acid. So, this deoxyhemoglobin I can understand like this, that it's a kind of alkali. So, that alkalosis has suppression or inhibition effect on this peripheral chemoreceptor. So, hypoxia is stimulating and this deoxyhemoglobin is inhibiting the peripheral chemoreceptor. Because of the balance of this, what will happen? The ventilation is not rising significantly when the partial pressure of oxygen is above 60 millimeter of mercury. But whenever the partial pressure of oxygen is below 60 millimeter of mercury, the stimulation by this hypoxia is so much high that it overcomes the inhibitory effect of deoxyhemoglobin. Getting my point? Apart from this deoxyhemoglobin mediated inhibition, there is another reason also. You know that? See, whenever there is hypoxia, it is stimulating peripheral chemoreceptor. Peripheral chemoreceptor stimulation means there will be rise in ventilation. Ventilation rise means what will happen? You are going to wash out the carbon dioxide from the body. If you wash out the carbon dioxide from the body, what is going to happen? Again there will be little alkalosis, and this alkalosis is going to inhibit the ventilation. So, this kind of inhibition is going on when the hypoxia is growing on more and more. But whenever the hypoxia is below or less than 60 millimeter of mercury, then the stimulation to ventilation is so strong that this inhibitory effect is negligible. That's why answer of this question is nothing but option number C, C and C. Got it, student? Hello student, we are going to discuss insta number 15. So the question is, which of the following statement is false about angiotensin II? So all of you know that angiotensin II has many effects in our body, right? For it's a potent vasoconstrictor, okay? Because of the vasoconstriction, it raises the blood pressure. Apart from that, it enhances sodium reabsorption from the proximal convoluted tubules. Apart from that, it stimulates aldosterone as well as releases epinephrine from the adrenal medulla. But here they are asking about angiotensin effect on renal vasculature. So what is the answer? Answer of this question is option number D and D. So, angiotensin II causes constriction of the afferent arteriole, so it reduces GFR. It's a true statement. Angiotensin causes contraction of the mesangial cells, and by which it reduces GFR. It's also a true statement. Angiotensin causes constriction of the efferent arteriole and it increases the GFR. It's also a true statement. Because it's a vasoconstrictor, it can causes constriction of both afferent as well as efferent arteriole. But in normal cases, in normal person, angiotensin reduces GFR very little. So that's why overall in normal condition GFR is slightly increased. No, this is a wrong statement. Angiotensin II reduces the GFR in a normal person. But you must have remember that effect of angiotensin II in a hypotensive person, suppose the person has severe hemorrhage, there is hypotension, there is heart failure. In all of those conditions, angiotensin II causes constriction of efferent arteriole more than that of the afferent arteriole, and by causing constriction of efferent more in pathological state like hypotension or heart failure, it maintains the GFR. Okay, so that's why you know that in this condition, like for example, when the renal hypotension is going on in case of renal artery stenosis, if you give angiotensin converting enzyme inhibitor, ACE inhibitor, then it can causes renal failure, because you are preventing the effect of angiotensin II here, that is nothing but constriction of efferent arteriole more than afferent arteriole. Now, if you don't believe this thing, because it's a you know that this area is a little bit confusing, so I have taken the reference from Goodman-Gilman. So it is exact thing which is written in Goodman-Gilman. I have prepared the question from there, that angiotensin II influences glomerular filtration rate by several mechanisms. Constriction of afferent arteriole reduces GFR, contraction of mesangial cells reduces GFR, constriction of the efferent arteriole which increases GFR, right, which increases GFR a little bit. Now normally GFR is slightly reduced by angiotensin II. However, during renal artery hypotension, the effect of angiotensin on efferent arteriole predominant, so that angiotensin II causes increase in GFR. So please remember, in this question everything is true statement, but this D is a false statement, because in normal person angiotensin II slightly reduces the GFR, but in pathological state it increases the GFR by this efferent arterial constriction more. Hello student, we are going to discuss insta number 16. So question is, which systems transmit somatosensory information with highest degree of temporal and spatial fidelity? So answer of this question is nothing but dorsal column medial lemniscal system. So what is the question about? So we all know that whenever the information is carried from the peripheral sensory receptor to the central nervous system or up to the level of cerebral cortex, there are multiple relay stations throughout the in the spinal cord also, as well as at the level of thalamus also, maybe at the level of medulla also. So if you think of the dorsal column pathway, then all of you know that the fiber from the periphery, they reach at the level of medulla, and at the level of medulla they make a synapse with the second order neuron, that is the nucleus of cuneatus and nucleus of gracilis. Then this nucleus of cuneatus and nucleus of gracilis, they crosses to opposite side and they ascend to form the medial lemniscal pathway, and it reaches up to the thalamus. From the thalamus, the third order neuron reaches up to the level of cortex. In case of dorsal column pathway, if you note down the pathway, then you will find out that first order neuron converges on the second order neuron, and this convergence is not very significant. That means only 1:1 type of convergence is seen. Only one type of fiber, only one type of first order neuron is going to converge on the one type of second order neuron. That means there is not very much convergence of signal. But in case of anterolateral pathway. If you look at the anterolateral pathway, that means the pathway which is carrying your pain, temperature, crude touch and pressure. The fiber which are coming from the level of periphery, they produce a synapses at the spinal cord level, and the second order neuron reach up to the level of thalamus. At the level of thalamus, we know that it converges on the VPL and VPM nucleus. But in case of anterolateral column, huge number of this second order neuron is going to converge on the same third order neuron. Because of this huge number of convergence, because of the huge number of convergence of the neurons in a single third order neuron, the fidelity of the anterolateral system is lost. But in case of dorsal column pathway, which is carrying the fine touch, proprioception, etc. sensation, the one-to-one connection maintain the fidelity. That's why the highest fidelity of the among all of this option is nothing but option number B, that is nothing but dorsal column medial lemniscal pathway. Hello student, we are going to discuss the Insta number 17. So the question is, which points on the following figures represent arterial blood in a severely anemic person? Severely anemic person. So let's look at. Although these two curves are looking similar, but they are not same. Because in first curve, the y-axis is the content of oxygen, and in second curve, the y-axis is oxygen saturation. Now, if you note down this curve more carefully, then you will find out that x-axis is partial pressure of oxygen. So we know our arterial blood partial pressure of oxygen is around 98 millimeter of mercury. So with this 98 millimeter of mercury partial pressure, we know the oxygen content of the arterial blood is around 20 ml per 100 ml of blood. So this D point is nothing but a point of a normal person. Similarly, on the second curve, partial pressure of oxygen is 98 millimeter of mercury. With this partial pressure, we know that saturation of our blood is around 97% saturation. So point D is again a normal person saturation point. Now what about anemic person? So anemic person means the hemoglobin is less. Hemoglobin less means hemoglobin bound oxygen is less, and we know in arterial blood the major oxygen is transported by hemoglobin bound oxygen. So if the hemoglobin is less, then the oxygen content of the arterial blood will also be lower. So this point number E is the point of anemic person. Okay, so anemic person means obviously the oxygen content of the arterial blood will be lower. But what about partial pressure of oxygen in anemic person? Remember, the partial pressure of oxygen in arterial blood in an anemic person is normal. Because of the normal partial pressure, what will happen to the saturation of the hemoglobin in an anemic person? Again, it remain normal. That's why I have taken here that this partial pressure of oxygen is normal, but the oxygen content is low. That means E point in the first curve is the anemic person. But in case of second curve, the partial pressure is again 98 millimeter of mercury in anemic person, but saturation is same with that of the normal person. That means again this point number D indicate this is from a anemic person. That means in curve A the point number E, and in curve B the point number D. So E and D, option number D is the answer of this question. So please remember, it is one of the important concept that anemia means the content of oxygen is less, but the saturation, that partial pressure, the dissolved oxygen, everything is normal in case of anemic person. And because of which you know that because the dissolved oxygen content is normal in anemic person, it cannot stimulate your peripheral chemoreceptor, although the hypoxia is occurring at the level of tissue. Got it? Hello student, we are going to discuss Insta number 18. So, input neuron to a diverging circuit causes the membrane potential of a target neuron to change from minus 65 to minus 55 millivolt. Which of the following best describe these changes? So it's a simple question. You know that it is saying that one neuron is making synapse on a second neuron, okay, and it is causing the changes of the RMP of this neuron. So suppose the RMP is minus 70 millivolt, okay, then the RMP has rises to minus 65 millivolt and it is changing the membrane voltage from minus 65 to minus 55 millivolt. So I can easily understand that the change of membrane voltage from minus 65 to minus 55 is nothing but local depolarization production on this postsynaptic membrane. And the local depolarization which is produced at the level of this postsynaptic neuron, this is nothing but excitatory postsynaptic potential or EPSP. And this EPSP is rising from minus 65 to minus 55 millivolts, obviously in a positive direction. And how much positivity? Plus 10 positivity. So obviously answer of this question is nothing but excitatory postsynaptic potential of plus 10 millivolt.